All right, good evening, everyone. So I think we're going to continue the part 2 of this talk. So I think on the first part of the talk, we have to discuss about the anatomy of the left ventricle, the right ventricle, the anatomy of all the valves. So we have also talked a little bit of basic echocardiogram, the difference between relative wall thickness and left ventricular hypertrophy. Okay? So today we're going to start back, and I wanted just to remind you about the cardiac cycle, okay, and what does the cardiac cycle entail. So if you look at the screen now, let's say it starts at the end of diastole. So at the end of diastole, so diastole is when mitral valve open and the blood flow from the left atrium to the left ventricle. So at the end of diastole, the mitral valve will close. So what happened at the end of diastole now? Okay, so you can see that at first the mitral valve will close and the aortic valve will also close. So this is what happened at the end of diastole. Both mitral valve and aortic valve close. So you are entering the phase that is called isovolumetric contraction, because mitral valve is closed, aortic valve is closed, but the LV pressure is actually going up and up and up, even though both of these are closed. So this is called isovolumetric. Why isovolumetric? Because both the valve is closed, so the volume is the same. However, the pressure goes up. So as the pressure goes up and up and up, the pressure inside the left ventricle will go higher than the pressure inside the aorta. So what happens is that the aortic valve will open and then you will enter the period of ejection. Okay, so the blood will flow from the left ventricle into the aorta. So this is the period of ejection here. Now, after the period of ejection, then the aortic valve will close. At that time, the mitral valve is closed. Okay, so this is end of systole. So at the end of the systole, both mitral valve is closed and aortic valve is closed. Because this is closed, this is also called an isovolumetric period. Rather than pressure going up, the pressure will going down. Okay, and this is called isovolumetric relaxation. So this is the beginning of diastole. The pressure inside the left ventricle go down, okay, but the volume is still the same until it comes to the point that the pressure inside the left ventricle is lower than the pressure inside the left atrium. Okay, and that is when the mitral valve opens and you have your filling of the left ventricle from the left atrium. So blood flow from the left atrium to left ventricle. This is called the left ventricular filling here. So the left ventricle will fill and fill until it comes to the time when the mitral valve closes again and you go back to the isovolumetric contraction. Okay, so I just wanted to remind you again that it's 4 parts of cardiac cycle. From this part to this part is what we call systole. From this part to this part is what we call diastole. At the beginning of systole, you have isovolumetric contraction, in which the pressure inside the left ventricle goes up, but the volume stays the same. Then you have ejection, the blood flow from the left ventricle into the aorta. Then again, both the valve close, and you have isovolumetric relaxation, in which the left ventricle relax, the pressure inside the left ventricle come down, but the volume is still the same, until you come to the part where the mitral valve opens and you got the flow of blood from the left atrium into the left ventricle. Okay, so you have these 4 phases of cardiac cycle. Now, when you look at this flow here, you will understand one thing, the concept of K index. K index is index of myocardial performance. So both the left ventricle and right ventricle have index myocardial performance. And what does this mean is isovolumetric contraction time plus isovolumetric relaxation time over ejection time. Okay, so the lower the value, the better is the function of your heart. Why? Because we want our heart to spend time more in the ejection period rather than in the isovolumetric relaxation and isovolumetric contraction time. Okay, so for example, the normal value for right ventricle myocardial performance index or K index is less than 0.43. Okay, duration of systole isovolumetric contraction and isovolumetric relaxation are longer for the left ventricle compared to right ventricle, and the duration of ejection is shorter for left ventricle compared to the right ventricle. And when you look at the equation for index of myocardial performance, or T index, because it involves the isovolumetric contraction and isovolumetric relaxation, so isovolumetric relaxation is part of diastole. Therefore, the T index is index of the heart that takes into account the diastolic phase, not like ejection fraction, which only take into account the systolic phase. Now, this is a busy slide, but it is important to remember. So, for example, if you wanted to train in cardiology, or if you are a master student and having exam, so this is part of your syllabus or the thing that you need to know. Okay, so I will just divide so that it's easy for you from the start of systole. From the small part here, this is the start of systole here. All right. So this is systole here, and we start with isovolumetric contraction. And then after that, from isovolumetric contraction, as the aortic valve open, we go into ejection time. Then both the aortic valve and mitral valve will close, and we go into isovolumetric relaxation time. As the left ventricular pressure go below the left atrial pressure, then you go into the period of diastole here. And from here to here, you complete the cardiac cycle. Okay, so I will go one by one. So this is the isovolumetric contraction time. Okay, so the red line here is the line denoting the pressure inside the left ventricle. This here is the pressure inside the left atrium, and this here is the pressure inside the aorta. Okay, and as you see, during isovolumetric contraction time, you can see that the pressure inside the left ventricle go up. So the pressure inside the left ventricle go up. However, the volume is still the same. Okay, so the pressure go up and up and up and up. What does the pressure in the left atrium done at this point? So you can see this bump here. This is called the C wave of the left atrial waveform. Okay, you know, when you look at the let's say you can put a catheter inside your left atrium, you can see a wave, the left atrial wave. Okay, so there is few different waves, and sometimes this wave is quite difficult to understand. The same goes if you put the central venous catheter into your right atrium. You also will get the pressure inside the right atrium. So both the pressure in the left atrium and right atrium have certain alphabet that we need to remember and we need to understand. So the first alphabet that we know, and this isovolumetric contraction, this is the C wave at the earliest part of the systole. So you have a C wave of left atrial waveform. Okay, so we go to ejection period. So when does ejection period start? So the ejection period starts once the left ventricular pressure is higher than the aortic pressure. So there's slightly higher left ventricular pressure than aortic pressure. So the aortic valve will open. So this is the time when the blood flow from the left ventricle into the aorta. Okay, so if you see the left atrial wave, so at the beginning you have the C wave here. However, after the C wave, at early part of diastole, you have this downward movement of the left atrial pressure there. That is what we call an X descent. Okay, so this is that C wave, and this is X descent. So what happened during the X descent? This is the time of left atrial relaxation, and this is time when the start of blood to flow from the left ventricle to left atrium. So the left atrium relax, therefore you get a situation called the X descent. So it's called the X descent here. All right. So at the middle of ejection, to the end of ejection, you have something called the V wave. So normally this V wave is small in normal people. So what is V wave? So the V wave is when the left atrium has now filled, and it fills more and more. So as it fills more and more, the pressure actually goes higher and higher. Therefore, if you were to have mitral regurgitation during this period of systole, you got a lot of flow from the left ventricle into the left atrium, and therefore you get something that is called a giant V wave. So this is a favorite exam question. When you see when you do a catheterization and you look and you see a giant V wave, if it's in the left atrium, that is mitral regurgitation. If it's in the right atrium, that is tricuspid regurgitation. Okay? So, C wave, X descent, and V wave. Okay? Now, as the left ventricular pressure go down and down and down, now the left ventricular pressure will be lower than the aortic pressure at this point of time, and then the aortic valve will close. Okay? So this period here is what we call isovolumetric relaxation time, in which the pressure inside the left ventricle coming down and down and down, but the left ventricular volume stay the same. Now, when the left ventricular pressure goes slightly below the left atrial pressure, so what happens? The mitral valve opens. So that is the beginning of diastole. Okay? So this is the beginning of diastole here, right? So what happened to the left atrial wave? So at the very beginning of systole, we have the C wave. At the early systole, we have the X descent. At the mid to late systole, we got the V wave. At early diastole, we got what we call a Y descent. So this is the Y descent here at the early diastole. So Y descent happen when at early part, when the mitral valve open, okay, and there is a rapid flow of blood from the left atrium to the left ventricle. Because you have the rapid flow of blood from the left atrium to the left ventricle, you have sudden loss of pressure inside the left atrium. So therefore, you have this Y descent in the waveform of the left atrium. At the end period of the diastole, you have this A wave or the atrial contraction of the left atrium, and then the cycle starts again. Okay, so let me repeat it. Looking at the left ventricle, during isovolumetric contraction, the left ventricular pressure go up and up and up and up. As it goes up and up, the pressure is higher than aorta. The aortic valve open, then you go into ejection period. Okay, so this is the pressure inside the left ventricle. Ejection period, it go up, then you go down back. So it go down and down and down, up into a time when the pressure inside the left ventricle is lower than the pressure inside the aorta, so the aortic valve will close. So you go into isovolumetric relaxation. So the pressure goes down and down and down and down until the pressure is lower than the pressure inside the left atrium. Then the mitral valve will open now. Okay, and then the blood will flow from the left atrium to the left ventricle at this period of diastole. So as you can see here, the diastolic period is longer than systolic period. What happened in the left atrium? At the beginning of the systole, you have the C wave here, and then you have the X descent at early systole because the left atrium actually relax. So you have lowering of the pressure as the left atrium relax. And then you have the V wave here as the blood flow into the left atrium from the pulmonary vein. And then you have the Y descent here as the mitral valve open and the blood rush from the left atrium to the left ventricle. And finally, you have an A wave here. This is an atrial contraction component to the left atrial pressure. So now I hope you understand few of these lines. Okay. I wanted just to remind you, if you look at this dotted line here, you can see that the left atrial pressure, if there is no illnesses or there is no pathology, the left atrial pressure varies, but it varies only in a little bit, very little. So if you look at this, and you look at left ventricular and diastolic pressure here, you look at left ventricular and diastolic pressure here, it actually approximates the left atrial pressure. So for example, when we do left heart catheterization, okay, and then you put your catheter inside the radial artery, and then you go into your subclavian, and then you go into your aorta, then you go into the left ventricle, so you can measure your left ventricle pressure. However, from the left ventricle, you cannot maneuver the wires to go back into the left atrium. So you cannot directly measure the left atrial pressure from left heart catheterization. So to overcome that, what you need to do is just to measure the left ventricular and diastolic pressure. So in the absence of mitral stenosis, your left ventricular and diastolic pressure is the same as your left atrial pressure. The same goes to right ventricle. The right ventricular and diastolic pressure is the same as right atrial pressure in the absence of tricuspid stenosis. This is just the phase of where diastole, you have the beginning of rapid inflow. And then at the middle of diastole, you have a moment where there's not much flow between the atrium and the ventricle. And finally, at the end, you have atrial systole. Okay? And this atrial systole is very important. This AV is very important because it contributes about 25% to the stroke volume. So therefore, let's say someone that has heart failure, but they are asymptomatic, and suddenly they develop atrial fibrillation. So in this situation, because they lose their AV, they lose their atrial contraction, so what happens is their stroke volume will come down and they will become more symptomatic. Always beware. Someone with heart failure from sinus rhythm and suddenly develop atrial fibrillation, they will then start to become symptomatic. So this just wanted to show you again what is the X descent and that is the Y descent. And I just wanted to show you as well at the period of systole, at the beginning of systole, even though the left ventricle pressure is slightly higher than aortic pressure, but it's not so much. So if you want to approximate, it is about the same. So therefore, your left ventricular systolic pressure in the absence of aortic stenosis is the same as your aortic systolic pressure. Same goes for the right heart. The right ventricular systolic pressure in the absence of pulmonary stenosis is the same as the pulmonary artery systolic pressure. So that's how we decide whether the patient has pulmonary hypertension or not when we do echocardiogram. Okay, so that's few things I will tell you about this diagram here. So you have to look at the pressure wave. So let's look at the number, and it is very important to know, especially if you are doing internal medicine, and definitely if you are doing cardiology. Okay, you cannot not know this. Okay, so if I were to put a catheter inside the left atrium and left ventricle, and if I were to put catheter into the right atrium, right ventricle, and pulmonary artery, what value can I get in terms of the systolic pressure and the diastolic pressure? Okay, so for you, those of you that is not familiar, so let me show you how we do the catheterization. So we can do either from subclavian artery or we can do from the femoral artery. So I will put in a catheter. So the catheter will go. So at first the catheter will go into the radial artery, into the subclavian artery, and then into the aorta. Then if I just measure the pressure there, then it will measure the central aortic pressure. If I push the catheter further downwards, it will go into the left ventricle. And I can measure the left ventricle systolic and diastolic pressure. As I tell you, it's difficult to turn back, so I cannot directly measure the pressure in the left atrium from the left heart catheterization. However, remember that the left ventricular and diastolic pressure approximate the left atrial pressure in the absence of muscle stenosis. So that's the left side of the heart. How do I measure the right heart of the heart? I also do catheterization. But rather than put it inside the artery, I put it inside the vein. So I usually can put it into the femoral vein, or you can put it into the ventricular vein. So the catheter will first go into the right atrium, and you can measure the pressure inside the right atrium. This is just your central venous pressure, the CVP catheter that you put in the hospital. Okay? If you were to put the catheter deeper, then you go into the right ventricle, and then you will measure your right ventricular pressure. Now, inside the right heart, it is actually possible for you to turn the catheter into the pulmonary artery. So then you can measure your pulmonary artery pressure. And furthermore, you can actually do one special thing with a catheter called Swan's-Ganz catheter. So Swan's-Ganz catheter is actually created by someone called Willie Ganz and also Jeremy Swan. Okay, I think Willie Ganz is an engineer. So in medicine, always when you see some model or some device, they always have two names. For example, we have a valve that is called Star Edwards or Bjork-Shahi. So the first name is the name of the doctor, and the second name is the name of the engineer. Okay, that come up with the device. So if you use the Swan's-Ganz catheter, you measure the right atrium, go inside, measure the right ventricle, and then go to pulmonary artery, measure the pulmonary artery pressure. If you were to push the Swan's-Ganz catheter all the way up to the end, you can actually wedge it. What do you mean by wedge it? We push it all the way inside, and we actually push it towards the end of the pulmonary artery and pulmonary capillary. So this is what we call pulmonary capillary wedge pressure. Why is it very important? So unless you have an atrial septal defect, there is no way to directly measure the left atrial pressure. Either you go left ventricular and diastolic pressure, or more commonly, when you do right heart catheterization, you push your catheter up to the level of pulmonary capillaries, and when you weight it, you will actually measure the pressure inside the pulmonary vein, and because pulmonary vein is connected to the left atrium, you will measure the pressure inside the left atrium. Okay, so that's how we measure it. What about the number itself? So you have to remember this number, okay? So right atrial pressure, the mean is about 3. So normally we're walking around with a pressure of 0 to 5 millimeter mercury inside our right atrium, okay? If we are fluid overload, then the pressure will be higher than that, okay? So this is right atrial pressure. What about left atrial pressure? So our left atrial pressure is usually less than 8 millimeter mercury, all right? Usually, you between 7 and 9 or 7 and 10 is really normal left atrial pressure. Okay, so I show you the main left atrial pressure. When your left atrial pressure go up and become abnormal, you have shortness of breath. Why is this? Because you will have back pressure to your pulmonary capillary, and you can leak fluid into your lung. So if your left atrial pressure is more than 15 millimeter mercury, you will develop shortness of breath because of increase in your left atrial pressure. So I just wanted to tell you the concept. Whenever someone is having shortness of breath because of cardiac issue, the reason they're having the shortness of breath is because their left atrial pressure is elevated, more than 15 millimeter mercury. And sometimes the way we help them is giving them diuretic. And as we give them diuretic, we actually reduce the pressure inside the left atrium. And when we reduce, say we reduce from 20 to 8, the patient will feel better and no longer having shortness of breath. Okay, so that is the left atrial pressure and right atrial pressure. And I hope you can remember that. And if you look at the left atrial pressure and right atrial pressure, the pressure inside the left atrium is always higher than the pressure inside the right atrium. So if you have the hole between the left atrium and right atrium, as in atrial septal defect, so what happens is you have the flow from the left atrium to the right atrium in both the phase of systole and also diastole. So the flow will be continuous, right? Now, what happens when we put our catheter inside the right ventricle? So we can have a systolic and diastolic pressure. So normal systolic RV pressure is about 25 millimeter mercury, and normal RV diastolic pressure is about 4 millimeter mercury. And let's look at the left ventricle. Now, the normal left ventricular systolic pressure is about 130, so that is the same as our aortic pressure. So your blood pressure when you measure on your hand. And the diastolic pressure of the left ventricle is about 8 millimeter mercury. Remember, I told you about atrial septal defect and the difference between the left and right atrial pressure. We can also understand ventricular septal defect. So what happens in ventricular septal defect? Look at the systolic pressure in the left ventricle and the systolic pressure in the right ventricle. There's a lot of difference between LV and RV. However, the difference in diastolic pressure between LV and RV is very little. So if you have a ventricular septal defect, you can see a high flow that is mainly during systole, as opposed to atrial septal defect. All right. Now, this is what I tell you before. Look at the right ventricle and diastolic pressure. It is almost the same as right atrial pressure, with one caveat that you don't have sarcastic stenosis. What about left ventricle? You can see that the left ventricular and diastolic pressure is the same as left atrial pressure, with the caveat that you don't have atrial stenosis. Okay, so this is the concept that is very important to know. Now, what about pulmonary artery pressure? And what about aortic pressure? Remember when I showed you the graph, the peak systolic pressure in the right ventricle, in the absence of pulmonary stenosis, is the same as pulmonary artery systolic pressure. So if you have your RV systolic pressure of 25 millimeter mercury, in the absence of pulmonary stenosis, your pulmonary artery systolic pressure will also be 25 millimeter mercury. This is only true for systolic, not diastolic pressure. And if you left ventricle, the peak systolic pressure is 130. The aortic systolic pressure will also be 130 in the absence of something that obstructs the left ventricular outflow tract, like aortic stenosis or subaortic membrane or hypertrophic obstructive cardiomyopathy. Okay. So I hope you are clear about this number that you need to know. Okay. And this PCWP is just pulmonary capillary wedge pressure, which is the pressure in the pulmonary capillaries that actually approximate the left atrial pressure. Okay, approximate the left atrial pressure here. Now I've shown you again the wave of the left atrium. So A wave, as its name says, is the atrial contraction. Okay, C wave is at the very beginning of systole. Okay, when the pressure inside the left ventricle go up and the pressure inside the left atrium also go up. The S descent is at early systole. So what happens during the X descent? The atrium is actually relaxed. So as the atrium relaxes, the pressure is actually come down. And this is the V wave. As the blood flow from the pulmonary vein into the left atrium, the pressure inside the left atrium goes up and up. So that's a V wave. And you can see giant V wave in patient with regurgitation, either mitral regurgitation for left atrium or tricuspid regurgitation for the right atrium. And then finally, you have what we call a Y descent here. This is actually an early diastole when the blood actually flows rapidly from the atrium to the ventricle. So I hope you know A wave, C wave, X descent, V wave, and Y descent from now onwards. Okay? Now, let's do right heart catheterization and understand right heart catheterization. Okay? But the first thing that I wanted to tell you is I wanted to show you one of the fundamental things that you need to know in terms of the pressure changes inside your heart. Okay? Now, the pressure inside your heart is called intracardiac pressure. Okay? Now, the pressure inside your lung and inside your pulmonary vein is called intrathoracic pressure. However, you have also pressure inside your SVC and IVC. So this is called the extrathoracic pressure. Now, in normal people like you and me, if we don't have pericardial disease, our intrathoracic pressure and intracardiac pressure go hand in hand. So as you inspire, your intrathoracic pressure will come down and your intracardiac pressure will also come down. And you expire, your intrathoracic pressure will go up and your intracardiac pressure will go up. So you see, on the left side of your heart, when you inspire, both go down. When you expire, both go up. So the gradient between the pulmonary vein and the left side of the heart actually the same in inspiration and expiration. Okay? However, if you look at the right side of the heart, as you inspire, the intracardiac pressure on the right go down. However, the extrathoracic pressure does not change. So when you inspire, the gradient on the right side of the heart go up. So on inspiration, there is more flow into the right side of the heart. Therefore, murmur on the right side of the heart goes louder on inspiration. Okay? As you expire, the intracardiac pressure go up on the right, but the extrathoracic pressure doesn't change. So the gradient come down. So there is little flow on the right side as you expire. So inspire, more flow on the right side. It push the intraventricular septum slightly to the left side, so there will be less flow on the left side. When you expiration, there is less flow on the right side. It pulls the septum to the right side, so you have more flow on the left side. So in this normal respiratory cycle, it is the right side that drives the changes, as opposed to someone with a pericardial problem, such as pericardial tamponade or constrictive pericarditis, in which the left side that makes the right side changes. Okay, so in normal people, right is what drives the change on the left side. So as you can see here, this is the ECG, and yet you inspire. So what happens to the pressure inside the right heart? So as you inspire, the pressure inside the right heart actually comes down. Therefore, the flow to the right side is more. And you expire, the pressure inside the right side of the heart go up. Okay, so there is less flow into the right side of the heart. And this is the concept that I want you to understand. Okay, and also the concept of interventricular dependence, meaning that the interventricular septum may play an important part. Now, because the left ventricle and right ventricle share interventricular septum, anything that happens to the interventricular septum will affect both the left ventricle and also the right ventricle. Okay, so this is the concept of interventricular dependence. Okay, and in the normal people, the change on the right side brings the change on the left side. Okay, that's why right-sided murmur is louder on inspiration and the left-sided murmur is louder on expiration. Okay, now this is a favorite example. Like what is an example example, when you have elevated airway, what is it caused by? When you have cannon airway, what is it caused by? Absent airway, what is it caused by? Okay, and I just wanted to remember airway is atrial wave during atrial contraction. So you have elevated airway because of tricuspid stenosis. So because there's so much to remember, you try to remember what I highlight. Okay, because this is maybe what will be asked during your patient exam. So elevated airway is in tricuspid stenosis. It can have cannon airway in patient with third-degree heart block. In atrial flutter or fibrillation, you lose the atrial contraction, so you have an absent airway. Remember, I say again and again, you have the giant V wave in the mitral regurgitation in left atrium and tricuspid regurgitation for right atrium. So this is what you have to remember, okay? That is a few things that you have to remember in terms of the waveform inside your right atrium. And when you look at X descent and Y descent, really the only two things that I wanted to remind you, the people always ask the difference between consecutive pericarditis and tamponade. Just remember that you have prominent X and Y descent and consecutive pericarditis. So in consecutive pericarditis, we have both prominent Y and prominent X descent. But in cardiac tamponade, we only have prominent X descent. Okay, that is the difference that you need to remember. So let's talk again about right heart catheterization. So this show you the right ventricular pressure. So you have the right ventricular systolic pressure here. Here is actually right ventricular diastolic pressure. So going up is systolic and down here is diastolic pressure. I already tell you the difference between isovolumetric contraction to ejection. So early part is systole is isovolumetric contraction. The middle part of systole is the ejection. And then after that, early part of diastole is isovolumetric relaxation. Okay. And then this long period here consists of three parts. Early rapid filling phase, the diastasis, where there is almost no flow between the right atrium to right ventricle or left atrium to left ventricle. And lastly, this phase of the atrial contraction. So this is the catheterization of the right ventricle. So what do you see? If you look at the screen and you catheterize the right heart, so this is what you see, okay? This is the pressure in the right heart. That is the systolic pressure inside the right pulmonary artery, okay? This is diastolic pressure inside the right pulmonary artery, okay? So systolic pressure and diastolic pressure. And sometimes you can see a notch there. You can see the notch in this when you catheterize the pulmonary artery. You can also see the same when you catheterize the aorta. So this notch here is called dicrotic notch. What is dicrotic notch? It signifies in the pulmonary side, the pulmonary valve closure in the beginning of isovolumetric relaxation time for the right side of the heart. For the left side of the heart, the dicrotic notch signifies the aortic valve closure. So this is the beginning of isovolumetric relaxation of the left side of the heart. So when you catheterize the pulmonary artery, you can measure the pulmonary pressure. And when you measure the pulmonary pressure directly, you can tell whether the patient has pulmonary hypertension or not. And you remember that pulmonary hypertension is a very important thing. Okay, remember that we have 5 WHO group of pulmonary hypertension. Group 1 is pulmonary arterial hypertension. This is young lady you see with idiopathic pulmonary hypertension, or your patient with systemic sclerosis, or your patient with connective tissue disorder, or your patient with HIV. We call it pulmonary arterial hypertension. And this carry a very bad prognosis. That's group 1. You have group 2 pulmonary hypertension. This is the most common group of pulmonary hypertension when you have pulmonary hypertension because of left-sided heart disease. Then you have group 3 pulmonary hypertension. Okay, group 3 pulmonary hypertension is someone with lung disease. Okay, someone, for example, with pulmonary fibrosis. Someone, for example, with long-standing chronic obstructive pulmonary disease. Group 4 is chronic thromboembolic disease. Someone with chronic pulmonary embolus. They will develop pulmonary hypertension. And the last group is miscellaneous. Okay, the thing that you cannot put in the first 4 groups. Okay, for example, maybe lymphangiectasis. For example, maybe things like splenomegaly. So all of that you put at the group 5 of pulmonary hypertension. So you ask yourself, what is the definition of pulmonary hypertension? you want to define pulmonary hypertension, you cannot do it with echocardiogram. A formal diagnosis of pulmonary hypertension must be done with right heart catheterization. Okay? And what is the number that you need to know? The number that you need to know is that when you do catheterization to define pulmonary hypertension, the mean pulmonary artery pressure must be more than 25 millimeter mercury. The mean pulmonary artery pressure is more than 25 millimeter mercury. And in group 1, group 3, group 4, group 5 pulmonary hypertension, the wedge pressure should be less than 15 millimeter mercury. Okay? The wedge pressure should be less than 15. In group 2 pulmonary hypertension, because it's left-sided heart disease, the mean pulmonary artery pressure is higher than 25. The left atrial pressure is also more than 15. So that's the difference between group 2 and the other groups of pulmonary hypertension. So when you do right heart catheterization, and this is the definition when you want to diagnose someone with pulmonary hypertension, this means pulmonary artery pressure that is more than 25 millimeter mercury. Once you have diagnosed the patient, the usage of echo, number one, is to screen. So when you do echo on someone and you calculate the systolic, CIC systolic, not mean, when you calculate the systolic pulmonary artery pressure and it's more than 40 millimeter mercury, that should alert you to the possibility of pulmonary hypertension. But you have to confirm it with right heart catheterization. Once you have confirmed it with right heart catheterization, you can actually follow up with echocardiogram. So you don't need to do right heart catheterization all the time. Okay? Remember, right heart catheterization is not just to measure pressure at each chamber of the heart. You can also do other things, such as you can also measure cardiac output. You can also measure pulmonary vascular resistance. So right heart catheterization is not only for pressure. So this is just an example for you, and I think I have this is like a beating a dead dog or a dead horse. Okay, so look at this left atrial pressure here, and you look at it at the end of the systole, you have a giant V wave here. At the end of systole, you have a giant V wave here. So for example, in exam, if I were to show you something like this, and I said, what is your diagnosis? You straight away will know that this is severe mitral regurgitation because of giant V wave. Okay, so that is the right side of the heart. Now, what about the left side of the heart? So this is the same. So you have this early isovolumetric contraction, in the middle is ejection, and you have isovolumetric relaxation time. You have an early rapid ceiling, in early diastole. At mid-segment, you have a period of diastasis. Then at late diastole, you have an atrial contraction. Okay. So what is this usage of left heart catheterization? Okay, number one, of course, you can measure your central aortic pressure, but you can do that with just your cuff. Okay, but you wanted to measure your left ventricular pressure. Now you have to remember that echocardiogram comes later than heart catheterization. Okay, so you know who actually first creates heart catheterization is a fellow named Werner Forssmann. He's actually a physician from Frankfurt, Germany. So he actually put a urinary catheter and he put inside his brachial vein, and he actually can push the urinary catheter up to right atrium, therefore showing that you can do catheterization into your right atrium. All right. However, the father of cardiac catheterization is a fellow called Mason Sohn. Mason Sohn, he's the one that's able to catheterize the left coronary artery and right coronary artery. Okay. So because before there is no echo, so how do you diagnose things like aortic stenosis? How do you want to diagnose things like hypertrophic obstructive cardiomyopathy? Because you don't have echocardiogram. I+1, you use your amazing clinical achievement. So you examine the patient, you see here a systolic ejection movement related to the cavity. Oh, this is aortic stenosis, or you do catheterization because a certain characteristic of the waveform tell you you are seeing a certain diagnosis. Example, let me show you here. Now, the top line here is the LV pressure. So this is an LV systolic pressure. However, you see this is an aortic systolic pressure. Now, remember, in the first picture that I tell you, LV systolic pressure should be the same as LV aortic systolic pressure. So what happens here? Why is the LV systolic pressure is higher than the aortic pressure? So there is a gradient. So there must be obstruction between the left ventricle and the aorta. So when they look at the waveform here, and you can see that it's the delay upstroke of the waveform. So there's delay increase in the aortic systolic pressure, okay? And the aortic systolic pressure is also lower than it's supposed to be. So this is called tardus, which is delay in increase of aortic pressure. And this is called forward, which is reduction in the amplitude of the aortic pressure. So you have a gradient, you have forward, and you have tardus. So you have gradient and forward and tardus. So what we have in this patient is someone with aortic stenosis. Okay. So if you measure the gradient from here to here, you can get what we call a peak-to-peak gradient in factorization. Now, if you were to calculate the gradient and you grade all these gradients here, you can get the mean aortic gradient. Okay. The mean aortic gradient is the same as usually the mean gradient in echocardiogram, unless we have something called pressure recovery. All right. So this example. So if I show you an exam here, straight away you will know. There is a LV systolic pressure, there is aortic pressure, there is a gradient there, and there is a delay in upstroke, there is a reduction of upstroke, there is forward, there is tardus. So this is the real aortic stenosis. Okay, that's forward and tardus there. Right? So look at that. Okay, there is delay and reduction in the aortic systolic pressure. And what about this? So this is if you put a catheter inside the aorta in someone with hypertrophic obstructive cardiomyopathy. So you will see some sort of aortic pressure still, and you can see the aortic pressure is like this. It is very, very different from the first one. The first one you have forward and tardus, but this one you actually have spike and dome. Whenever you see an aortic systolic pressure that has spike and dome configuration, you are actually having hypertrophic obstructive cardiomyopathy. Why they have spike and dome? Because they have mixed systolic closure of the aortic valve when there is obstruction because of systolic entry motion of the mitral valve. So if I were to show you this diagram, I will ask you, what is the spot diagnosis? You straight away know, there is a spike and dome pattern, so this might be hypertrophic obstructive cardiomyopathy. All right. So I show you again this slide so that you can remember the pressure inside the left side of the heart and right side of the heart. Believe me, even some cardiologists don't understand this. All right. So I hope you all understand until this part. Okay. So I have teach you a lot. Okay. I have teach you about the pressure on the left side, the pressure on the right side, basic on the left heart catheterization, basic on the right heart catheterization, the atrial wave on the left atrium and right atrium, the A wave, the C wave, the X descent, the V wave, and the Y descent. So, and if you don't understand anything, please put a question inside the chat group. Okay. So we leave this part now, and then I want to go into something called stroke volume and stroke volume index, something called cardiac output and cardiac index. Okay. Now, stroke volume is the amount of blood pumped in a single beat. So a single beat, how many cc of blood go up from the left ventricle. Okay. Now, stroke volume index is that stroke volume divided by your body surface area. So you have to remember that normal stroke volume is between 60 to 100 mil. So how can you have low stroke volume? So you can have low stroke volume with poor ejection fraction. You can have low stroke volume with small left ventricular cavity. You have poor stroke volume because of your mitral regurgitation. So that's an example of low stroke volume, and you can have shortness of breath. Now, a lot of people talk about low stroke volume, but they forget about heart. And too high is also not good, and sometimes you can have this high output cardiac failure. For example, if you have anemia. For example, if you have neurotoxicosis. And for example, if someone with AV fistula, okay, that is unused. Now, normal stroke volume index is 35 to 65 mL per meter squared. This is also important. It's very important. You know, if let's say you want to do cardiology and you want to understand echocardiogram, there is a lot of things need understanding of stroke volume. For example, in the phenomenon of low flow, low gradient severe aortic stenosis, in which you have to understand what is the reason of the low flow. That is stroke volume and stroke volume index. Now, cardiac output is the volume of blood the heart pumps per minute, meaning that stroke volume times your heart rate. So if your stroke volume is 75 mil, so your heart rate is 75 times 60. So your cardiac output is stroke volume times heart rate, which is 75 mil times 60 per minute. And your cardiac output is 4,500 mils per minute or 4.5 liters per minute. So normal cardiac output is 4 to 8 liters per minute. So you have to teach you, and you have to remember the normal stroke volume 60 to 100. You have to remember the normal stroke volume index, 35 to 65 mL per meter squared. You have to remember the normal stroke volume, the normal cardiac output, which is 4 to 8 liters per minute. And another thing that I wanted to teach is cardiac index. So same as stroke volume index, this is cardiac output divided by body surface area. So someone with cardiac output of 4.5 liters per minute and body surface area of 1.25 meters squared. So when you calculate the cardiac output, it's 4.5 divided by 1.25. So the cardiac output is 3.6 liters per minute per meter squared. So the normal cardiac index is 2.4 to 4.2 liters per minute per meter squared. So remember, stroke volume index, cardiac output, and cardiac index. It is very important. How do we measure cardiac output? So remember that I tell you before this, you don't have to cardiogram. So one of the ways to measure cardiac output is we have to do catheterization. So there is two methods to get cardiac output from catheterization. There is two methods. And they might ask you, because in the basic of cardiology, you have to understand it. One is what we call a fixed method, F-I-C-K-S. Another one is what we call a thermodilution method. This is what we often do now, is thermodilation. We don't do fixed because fixed is cumbersome, but fixed is supposed to be more accurate and more standard. So two, fixed and thermodilution. So what is the principle of fixed? So the principle is the total uptake or release of a substance by the peripheral tissues. Okay, the peripheral tissues usually we say is the lung. Okay, it can be other things, but because we are measuring from catheterization, we say the lung is equal to the product of the blood flow to the peripheral tissue. So blood flow to the peripheral tissue is your cardiac output, and the difference between the concentration of your arterial and venous substance. So if we're talking about measuring the lung and oxygen consumption of the lung, so I can change the principle thus, okay? The total uptake of release of oxygen by the lung is equal to cardiac output to the lung and the change in concentration between the artery and vein of a substance, for example, oxygen. Okay, so oxygen consumption by tissue is equal to cardiac output times the difference in concentration between oxygen in artery and vein. So if you were to rearrange the equation, cardiac output is equal to the total utilization of oxygen or oxygen uptake divided by difference in concentration of artery and venous of the oxygen. Okay, so this is the fixed method. It's the purest and most accurate means of estimating cardiac output. It's not confused by low output state, valvular regurgitation, shunt, or arrhythmia. The major source of error is the act of measuring the amount of exhaled oxygen and the change in cardiac output over the period of measurement. So this is the principle in detail. So I just wanted you to remember. A lot of people just don't bother about this, but just remember the way you do cardiac output, but two, one is fixed, one is thermodilation. So let's look at the fixed principle in detail. Okay. So the oxygen consumption is simply the difference between the inspired and expired oxygen. So if you want to measure the oxygen consumption, you have to attach a box into patient head and measure the oxygen consumption, or you can also estimate the consumption. Okay, because normally people will consume the same amount of oxygen during resting time. So a resting metabolic consumption of oxygen, we assume as 3.5 mL of oxygen per kg per minute. So this is oxygen consumption. All right. And remember that cardiac output is equal to oxygen consumption versus the difference of concentration in artery and the vein. So that is your cardiac output. And you have 125 mL of oxygen per square meter of body surface area per minute in terms of oxygen consumption. So for example, imagine that this is your patient here, all right, this is your lung tissue. So you measure the volume in and the volume out. Okay, you measure the concentration in and the concentration out. So this is the oxygen consumption. This is the difference in oxygen concentration. Okay, so this divided by this is your cardiac output in liters per minute, right? So we can rearrange that to form an equation. So for example, if 250 mL is your oxygen consumption, and this is the difference. So this is your arterial oxygen, this is your venous oxygen. So this divided by this to get your cardiac output, which is 5 liters per minute. So this is the direct fixed method. So if you still don't understand, I have a diagram for you. So let's say this is a patient here, okay? So what we do is we take a venous blood, we take an arterial blood. So this is the difference in their concentration. So this is denominator of the equation, okay? From here, we measure the oxygen consumption. This is the denominator. So if you divide this by this, you get your cardiac output. So this is the fixed method. The problem with the fixed method, of course, the measurement of this oxygen consumption might not be accurate, and it is unmeasurable. All right. So I hope now you understand fixed method. Now, the one that we do now is thermodilution. Okay. What is thermodilution? This is slightly more difficult to understand. Okay. Now, look at the history. In 1897, a fellow called Stewart injected a bolus of sodium chloride solution into the central venous circulation of anesthetized dogs and rabbits. Just so you know, okay, a lot of surgery last time was done in animal life and done in dogs. For example, the correction of mitral stenosis, the correction of pathology of fellow, coronary artery bypass, all are done in dogs first. Okay. So, and then collected blood samples containing diluted sodium chloride from femoral artery catheter. An electric conducer on the contralateral femoral artery sensed the arrival of diluted injected. Okay, so he put a bolus of sodium chloride solution, all right, and then he take back the sample, but the diluted sample in the femoral artery. Okay, so what he do? Is that he take the blood in the femoral artery at different times. For example, 5 seconds, 10 seconds, 15 seconds. And as you inject a substance, that concentration of the substance will come down. So when he sees the reduction in the concentration within 5 seconds, 10 seconds, and 15 seconds, what happens is that, okay, he can plot the graph. One axis is time at the x-axis, and y is in the concentration, all right? And from this, he can calculate the cardiac output by divide the amount of injected indicators, so the more that is injected, over the area of dilution curve. Okay, he used sodium chloride. However, after that, people use something called indocyanine green as an indicator. All right. So what do? Put a certain amount of injected indocyanine green. So you know the concentration of indocyanine green. You have another place where the indocyanine green is over through your blood circulation, and then you take blood. And then you take blood at different time intervals. For example, 5 seconds, 10 seconds, 15 seconds, 20 seconds. And this rate of rise and coming down of concentration, if you plot it on the graph of concentration over time, you actually can get your cardiac output by dividing the amount of injected indocyanine green and the area of dilution under the curve. Okay, so the calculation is cumbersome. I also don't know how to do the calculation. However, usually the machine will do it for you. So if you do capitalization and you do thermodilution, you can actually calculate it automatically. Okay. Now this is dilution of a substance. However, the one that we use most often now is not this. The one that we use most often now is what we call a thermodilution method. Rather than looking at the increase in the concentration of a substance over time to get the cardiac output, we actually look at the rise and reduction of temperature. You know, as the blood flow, it actually reduces temperature because the heat dissipates. So what happens is you can measure temperature at different points where the blood is flowing. So at one point, this is the temperature. Another point, that is different temperature. So what happens is, rather than plotting the concentration against time, you plot the temperature against time. And the area under the curve is your cardiac output. Okay, so that is doing by temperature, not by concentration. All right. So the thermodilution method adapts the indicator dilution principle to injected that cause changes in blood temperature that we injected downstream. And injected of known volume and temperature is injected into the right atrium, and the cool blood traverses a thermistor in a major vessel branch downstream over duration of time. The cardiac output is inversely proportional to the mean blood temperature depression and the duration of transit of cool blood, i.e. area under the curve. So this looks like a lot of words, but the principle is just what I tell you. Okay. So again, SWAT class go into the right atrium and go into the right ventricle. So we inject a cold solution. So what happens is they will measure the temperature at 0.1. So it will measure the temperature at 0.2. It will measure the temperature at 0.3 and 0.4. Okay. So temperature here, here, and here, and here, as the blood go from here to there. So the temperature will go up, all right, and then will go up. So you can see the temperature go up and then go down. So this is at 0.1, 0.2, 0.3, and 0.4. So because you can plot the change in temperature over the time, so you can use it to calculate your cardiac output, which is the same as what I told you before. Only now the denominator is the numerator is the temperature, and the denominator is area under the dilution curve, the temperature under the curve. Okay, that is how you measure cardiac output using the thermodilution method. Okay, so you know the change in temperature over time, right? And you will know when you look at area under the curve the cardiac output. All right. So this is the formula. You can see that the formula is very complicated. All right. However, you do not need to know this formula. Okay, they will calculate it for you. All right. So it's just to make it complete. So cardiac output is equal to volume of injected times the change in temperature measured downstream minus the temperature of injected times the specific gravity of injected and blood over specific heat of injected and blood times 60 over, I think this is the integration of the change of temperature measured downstream. Okay, so this is a mouthful, so you don't need to remember all this. I just wanted to remind you again, we have two ways to measure cardiac output. Number one is fixed method. Fixed method is that you know that the consumption of a certain substance of the organ, for example, oxygen of the lung, divided by difference in concentration of arterial and venous is equal to cardiac output. In thermodilution method, you look at the change of temperature over time and over the distance of the catheter, and the area under the curve corresponds to cardiac output. And what we do more now is thermodilution as opposed to fixed method. What is the source of error of thermodilution? Okay, so it is unreliable in severe tricuspid regurgitation. Baseline temperature of blood in pulmonary artery may fluctuate with respiratory and cardiac cycles. Loss of injected with low cardiac output state due to warming of blood by walls of cardiac chamber and surrounding tissues. The reduction in change in temperature and pulmonary arterial septic site will result in overestimation of cardiac output. Lastly, it is the empirical correction factor corrects for catheter warming, but will not account for warming of injected and strained by the hand. All right. So that is how we measure with catheterization. But lastly, now we have echocardiogram. Okay, that settle and give us solution to a lot of problems. Okay, that's why that is my passion. So you look at echocardiogram here. This is a parasternal long axis view of a heart. So this is the mitral valve. So that's anterior mitral valve fixed, posterior mitral valve fixed. That is the atrium and that's the ventricle. That is the left ventricular outflow tract. Okay. So what happens is we assume that the left ventricular outflow tract is a cylinder. And you know a cylinder, the base of cylinder is actually a circle. It is actually in real life not really a perfect circle, but we assume that it is a circle. Okay. So if we were able to measure the radius and we put it into a calculation of the area of circle, which is pi r squared, then we get the area of the circle. So what happens is we can put a Doppler at this left ventricular outflow tract, and we can get this Doppler profile. This Doppler profile actually shows the movement of blood from the left ventricle to the aorta. So if you were to trace this contour, you will get something that is called velocity time integral. So what is velocity time integral? Now, velocity time integral is the distance a single blood cell travels in one heartbeat. Okay, velocity time integral is the distance a single blood cell travels in a single heartbeat. So if you have the area here, because you measure that, then you have the VTI, which is the distance the blood flow in one beat. So this times the pi r squared, then you get volume of the blood that go in a single beat. So the pi r squared here times the LVOT, velocity time integral, you got your stroke volume. You got stroke volume, you divide divide the stroke volume by body surface area, you got stroke volume index. You times your stroke volume with heart rate, you got your cardiac output. You divide your cardiac output, your body surface area, you got your cardiac index. Okay, that is how I measure it in echocardiogram, right? Now, I also wanted to tell you the concept of vascular resistance. Okay, so we know that, for example, someone with pulmonary hypertension, they have increased pulmonary vascular resistance. This increased pulmonary vascular resistance cause the right ventricle cannot pump against it, so the cardiac output will come down. This happens also in left ventricle. For example, someone with hypertension, they have increase in afterload, therefore they have increase in vascular resistance. So how do we calculate vascular resistance? We calculate it by this law called Poiseuille's law. I don't know whether I pronounce it correctly. It's like a French name. So resistance is equal to the change in pressure, which is the pressure at the proximal portion minus the pressure at the distal portion over the cardiac output. Okay. Now the change in pressure is 8 with times the constant times the length of tube over 5 times by radius to the power of 4. So in vascular system, okay, and you can see this is more than exponential. So as your vessel becomes smaller and smaller, and this can happen in pulmonary arterial hypertension, your resistance go up. Okay, as your vessel becomes bigger, your resistance actually becomes low. So this is the basis of ACE inhibitor, based on angiotensin receptor blocker. They got vasodilation and reduce vascular resistance. And vascular resistance, the unit that we use to is what we call Wood's unit. Another way to calculate vascular resistance is to actually see the driving pressure. So, for example, okay, let me tell you, how do you want to calculate pulmonary vascular resistance? The way to calculate pulmonary vascular resistance is the distal part is the left atrial pressure, the proximal part is pulmonary arterial pressure. Okay, so left atrial pressure minus pulmonary arterial pressure over cardiac output, you get pulmonary vascular resistance. So the distance, which is the left atrial pressure, minus the proximal, which is pulmonary pressure, divided by cardiac output, you get pulmonary vascular resistance. Okay. What about systemic vascular resistance? So you have your aortic pressure at the end of the aortic pressure, so that's your left ventricle, pump the blood into aorta. At the end, it comes back into the right atrium. So aortic pressure, the mean aortic pressure, minus the right atrial pressure over cardiac output, that is systemic vascular resistance. Right? So let me show you again. Systemic vascular resistance is mean aortic pressure minus mean pressure in right atrium over the cardiac output. Pulmonary vascular resistance is pressure in the pulmonary artery minus pressure inside the left atrium over cardiac output. Okay, so this is the way to calculate, and the formula can be in Wood's unit or can be in metric unit. In Wood's unit, so it's just WU. Metric is time per second per centimeter negative 5 there. Normal value for systemic vascular resistance is 10/20. Normal value of pulmonary vascular resistance is 0.25 to 1.5. Okay, so if you have pulmonary artery hypertension, so group 1, group 3, group 4, group 5, your pulmonary vascular resistance will go up. If you have group 2 pulmonary hypertension, because of your left-sided heart disease, your pulmonary vascular resistance will not go up. The only thing that go up is the left atrial pressure. You see, left atrial pressure go up, PA pressure go up, your PVR will be the same. PA pressure go up, your left atrial stay the same, your pulmonary vascular resistance will be higher. Okay, and the threshold to cause something pulmonary hypertension is everything that is higher than 3 Wood's unit. So anything that is higher than 3 Wood's unit is considered pulmonary arterial hypertension. All right. So that is vascular resistance. Another thing is, if you wanted to know, now we can calculate mitral stenosis. You can calculate the VAS area from echocardiogram, which is 220 divided by pressure half time. Okay. Aortic valve stenosis, you can use quantity equation. What goes into the left ventricular outflow tract is the same of what goes out in the aortic valve. But how do they do this during the time of catheterization? So it actually was derived by someone called Richard Gorlin. So he actually do this Gorlin equation, and he looked at the mean gradient of the aorta and the mean gradient of left ventricular outflow tract, and he derived this equation that area is equal to flow divided by the coefficient of velocity times 44.3 times the square root of mean gradient. So this is the Gorlin equation. So if people ask you, how do people derive the microvasc area or ITIC area before the time of echocardiogram? They derive from catheterization by virtue of Gorlin's equation. Right? So let's stop now. So let's just remind us that I have teach you about the left ventricle, the right ventricle, the value of the pressure inside the left ventricle, value of pressure inside the right ventricle. I've told you why in ASD you have continuous flow in systole and diastole, why the VSD, the flow is only during systole. I have told you that LV and diastolic pressure is the same as LA pressure in the absence of microstenosis. RV and diastolic pressure approximate RA pressure in the absence of catalytic stenosis. LV systolic pressure is the same as aortic systolic pressure in the absence of aortic stenosis. RV systolic pressure is the same as pulmonary artery systolic pressure in the absence of pulmonary stenosis. We have learned about A wave of atrial contraction, C wave at the very earliest of systole, X wave at early systole because of atrial relaxation, X descent. We have learned about V wave. We also have learned about Y descent. I have teach you how do we measure cardiac output by both FICKS and also Thermodilution formula. We look at the formula to calculate pulmonary vascular resistance. Okay, so there's a lot to take in one lecture. Okay, so this is the end of the second part of our lecture. The third part of our lecture will be on echocardiogram, the basic of echocardiogram. It won't take that long, I think. So you can tell me in the chat group when do you want the next lecture to be. So I thank you for your participation. So feel free. So I'll give you about 5 to 10 minutes to ask questions inside the chat book. Okay, the chat room. So thank you very much of joining me in this.